Right. Thanks so much. I hope you can hear me well, and I hope that I am sharing my screen and you see the title page for the presentation.
Yes.
Excellent. Okay. So this is the inaugural webinar in a series that we're hosting as part of the immunization special interest group. And so thanks everyone for coming out to this. And I just wanted to let you all know, as you probably already do, that there will be several more presentations and quite a few of them on the topic of COVID economics as well. Today, I'm going to present work that I did with a large group of collaborators in trying to estimate the cost of delivering COVID vaccines. And this was work done on behalf of the COVAX facility, which is procuring vaccines to deliver to mostly low and middle income countries. I'm going to refer to them as the AMC 92 economies. These are basically 92 low and middle income countries. And it's work that was done, with a lot of collaboration and help. And I wanted to particularly acknowledge the Allison Portnoy, who's a colleague of mine at Harvard, and also Laura Boonstoppel and Christina Banks at ThinkWell, Logan Brenzel, and Ula Griffiths, who sort of has been leading this particular costing work group for COVAX that generated this work. The COVAX working group on delivery costs involves a number of organizations, as you can see there, and has a charge to help inform estimates of the cost of delivering COVID vaccine, to help with resource mobilization, estimating costs, and for planning and budgeting at a country level, and to also help inform, where things stand in terms of financing gaps or who's going to pay for what and so forth. Today, I'm really going to just focus on the initial batch of work that we did, which took place mostly last fall into the early spring, but I'll also touch on some of the things that we're still doing, some of the things that we're still doing now to refine estimates as COVAX refines its strategy and so forth. But indeed, to the point in the chat, most of the results I'm presenting are the results that were made public in around February of this year. But I will show you some of the more up-to-date things that we're doing. This has been sort of a rapid response type of project with several iterations. We were tasked with developing, and I call it an ex-ante costing model, because there's no empirical evidence at the time of how much it costs to deliver COVID vaccine in these settings. So we had nothing we could observe to understand what it actually costs. So we were making cost projections based on assumptions and what we know about delivering other vaccine programs. And it's focused on these COVAX countries, the AMC 92 countries. These are the group of countries that's not self-financing. Our first meeting was in the summer of 2020, and we had some initial estimates, very crude ones, by September 2020, and then we refined those, and what I'm showing you now is what the refined version of those estimates from January, February 2021. And since then, we've been asked to sort of make a version 2 of the model to accommodate more flexibility in exploring different scenarios and so forth. I think that the task, that the work that we had to do, the task, we had to build this model, and we had some requirements in terms of structure and function. So we wanted to have the costs broken down by certain line items, which I'll show you in a minute. And for those different line items or cost categories, we had to choose an appropriate sort of scaling unit. So are these costs that we were going to calculate per dose or per facility or per country? And later also thinking about, per facility or per country over some unit of time. And I'll show you that as well. Another thing that we, had to separate out were costs that were sort of investments or one-time startup costs to get the program rolling. An example of that might be buying cold chain equipment, additional cold chain equipment, versus recurring costs, which would, continue as long as COVID vaccination was taking place. The model also had to accommodate, be done at a country level, and it had to be able to handle scenarios where different target populations of different sizes were prioritized. So, like vaccinating healthcare workers first, and then vaccinating the elderly of a certain age, and so forth. And it had to have coverage targets for those different groups, and had to accommodate in a mix of delivery strategies for reaching those groups. So, and principally, we boiled down the delivery strategies into 2 modalities, which is really fixed site and an outreach or campaign. You'll notice that you can imagine other delivery strategies that are more nuanced, like big concentrated campaigns, like a mass campaign, which is, you really make a push over a very short period of time, versus sort of doing outreach every day over a period of months. So there's different types of approaches. You can also imagine doing outreach to certain institutionalized populations that are at higher risk of COVID. And in some countries, that's part of the strategy, but some of that nuance is not in this model. But we do have basically a bifurcation of a delivery modality that's a fixed site, sort of inside a healthcare facility of some type, typically, and some sort of outreach. And the principal difference between those is that the outreach involves extra costs in terms of per diems for the workers and transportation costs for the workers. Those are the main differences for that modality. In version 2 of the model, which I'll show you at the end, we've expanded the time frame so that instead of in the initial model, we just basically had assumed everything was going to happen within a 1-year period. And it all happened at once in the model. But in version 2, we break time into 6-month periods, going through the end of 2022, or actually can go till 2023, if desired, to accommodate sort of scenarios that might take place over a longer period of time. In version 2, it also became necessary to account for the level of vaccination that had been reached so far, because at the beginning, nobody had been vaccinated when we started working on it. But at this point, several countries had made a lot of progress already vaccinating significant portions of people. And so we had to accommodate that to make sure that we're not sort of double counting those. And that also raised issues in terms of when you have a program that's already ongoing, how do you handle some of the fixed costs or startup costs? Do you assume that those have already been invested, or that only a portion of them have? So there's a new set of issues that comes with trying to estimate these costs now that vaccination is already ongoing in some places. And then also in the new version, we were asked to add human resources. So the labor cost of delivering the vaccine was not something that COVAX was interested in the first iteration of the model, which I'm mostly focusing on today. But then subsequently, there have been stakeholder groups that are interested in understanding either the opportunity cost of the labor involved, and some interest in understanding whether there are additional labor costs, meaning that additional people need to be hired or paid overtime or something in order to facilitate delivering the vaccine. So we've now got those components in the model. And then finally, the other thing we added to the new model is the possibility of strategies that involve a booster shot for certain target populations. And once we had the sort of scope of the model and what its function was going to be, then we had to go through a fairly rapid process of data gathering to inform our unit cost estimates for the different line items. And that was done in a number of different ways. For certain line items, you can think of your PPE or your hand hygiene, sanitizer, wash stations, things of that nature. We could go to the literature and find decent estimates of unit costs for those items, and then we just had to figure out how many of those were likely to be consumed, per day or per dose in different delivery modalities. And there was a good amount of information in the literature already, from routine immunization costing studies or campaign costing studies, including the recent Ebola experience, which is probably the most similar analogy to what's going on with COVAX, although it's obviously was focused in fewer countries. There is also a challenge in figuring out how to make the costs country specific. So what were the appropriate adjustments to make to these costs? So maybe things like tradable goods like a hand wash station or a mask or gloves are something that where you're going to assume is a constant cost no matter the setting. But other costs like per diems or things that tend to be non-tradable within the country are more likely, it's more reasonable to assume that those unit costs are going to be different from country to country. And I should also mention that for some of the items, we relied heavily on other working groups within COVAX so there was a group that was modeling the cold chain requirements for COVID vaccine. So and they were doing that at a country level for a similar scenario. So we basically relied on their estimates and entered those into our model as more or less a black box. So I just want to, and that's also true for our estimates around technical assistance requirements, where there was a separate group that worked very hard to estimate how much technical assistance labor was going to be required, and we just plugged in the numbers that they gave us. In terms of the line items or categories, you can see them here. And these were picked partly to map to the other strategic planning documents and tools that were being used for COVID planning, like the National Vaccine Deployment, COVID Vaccine Deployment Plans, and NVDPs, and there were several other sort of planning documents that had categories of this nature. So we tried to stick to those categories. And so we have, things like planning and coordination, training, social mobilization, cold chain equipment, that's the equipment itself. And then we have PPE, vaccination certificates, syringes and storage boxes, safety boxes, per diems, transport, and technical assistance. And you can see here, and I'll try and explain this further on a future slide, that these were calculated at different levels of detail. So we have estimation of the cost of vaccine transport or waste management or per diems. Those were estimated at the dose level. So they vary basically, we have a unit cost that gets multiplied by the amount of doses delivered. For other categories, the scaling unit was the number of facilities involved. So, training, for training is an example where we said, instead of having a training cost per dose, it makes more sense to think about the training as per facilities. So you have some training activities that are going on, at the health facilities. And so the training was a multiple of the number of facilities. And likewise, with social mobilization activities, there were activities which were run out of facilities and also national level social mobilization. So there you have facility and country. This maybe explains it better. This is from the current model, which breaks your costs into those that are incurred per dose. And this shows you the items that are calculated as being incurred per dose. So the cost of these items is multiplied by the number of doses either delivered through fixed sites or through outreach. And you can see that through outreach, the main difference is that you have some additional costs for per diem and for transportation of personnel. Then we had some costs which are recurring costs, but they're not variable with the amount of doses delivered. They're more variable with the duration of time that the COVID vaccination campaign goes on. And so the examples here are, so these are costs that would be incurred every 6 months of the program. And those are for training, planning and coordination, social mobilization, pharmacovigilance, and technical assistance. So those are costs which would recur every 6 months. And then we have some costs that are incurred one time only at startup. The classic one for this would be your, which inexplicably I left off the list, but the classic one is your cold chain equipment, which we are assuming the cold chain equipment is a capital purchase. It's a one-time, it's treated in this model as a one-time thing. But then there are a number of other things which would have a startup component to them. And you'll see that some of the things have both a startup component, but then they also show up as being incurred every 6 months. And that really basically allowed us to have the flexibility to have a high cost at startup and then a smaller cost for training, every 6 months for ongoing training, or maybe there's a big cost of social mobilization up at the start, and then a lower recurring cost every 6 months thereafter. And I just wanted to give you a flavor. I can't go through all of them in the time that we have, but I wanted to give you a flavor of the kind of work that was done to try and extract information from the literature to inform our estimates. And this work was done primarily by the group at ThinkWell, so big shout out to them. But this is where they went through studies of, costing studies of various campaigns. And here I'm just giving you an example of one line item, which is vaccine certificates. And by the way, I do see that a number of questions popping up in the chat, and I will come to those, but I just don't want to get too derailed, so I'll come back to those, but I'm monitoring that. Thank you. So the cost per, this is one example for vaccine certificates. And so in the budgets for various campaigns in different countries, here we have 3 data points, 16 cents, 8 cents, 3 cents per person per dose for these vaccines. And then also from the, this is the IDCC is ThinkWell's International Delivery Cost Catalog for it's basically a database of vaccination costing literature. And from there, you can see, they had some cost per dose. And these are not budgets like the ones above, but the actual estimates of what it actually costs. And in any case, they ThinkWell picked a median cost there, which we used as our sort of base case estimate. Here's another example. So this is the transportation cost per dose for service delivery, supervision, and monitoring activities. So this is transportation, not of transportation of vaccine, but transportation of people. And we had a number of examples from house-to-house campaigns for polio. And ThinkWell did some work to adjust this for session sizes to get more plausible numbers. And then there were several studies on routine outreach and what the transportation costs associated with that are for routine outreach. And then there was also a data point from the oral cholera vaccine in Bangladesh. So, taking this data together, they once adjusted for session size, they had 49 cents, per dose as the number that we would plug into our model. This actually gets, I'll just note that this number actually gets further adjusted to account for cost variation across countries. And I'll come to that in a minute. So some of the items like per diems and transport of people and training, we adjusted to try and make them country specific in a way that basically it tends to be that in higher income countries, these costs are higher. But the adjustment factor was derived from the paper that's cited here, Alison Portnoy's lead author on making, where she did some econometric analysis to make estimates of the country costs of delivering routine immunization or campaigns. And it's broken down. And so and you have variation in those estimates from country to country. This is based on regression of all the data that's in the IDCC, that database that ThinkWell maintains on delivery costs of vaccination. And so we created these standardized unit cost estimates for delivery cost of immunization. And these were basically used, the ratio of these estimates across countries was used to adjust these particular line items in our costing model to basically account for, the fact that, larger countries and richer countries or poorer countries tend to have, those those are determinants of these costs. And just one more example briefly here, social mobilization category had a few line items. There were, and these line items were arrived at through sort of consulting with stakeholders within the COVAX group and its partners around what activities should be included, and then we costed them in different ways. So there was one aspect of social mobilization had to do with behavioral and social data collection, and we decided to implement that at the country level rather crudely, with a default cost of $30,000 per country. But if the country was a larger size country with population of over 10 million, or it was a fragile state conflict zone, we assumed those costs would be higher, $100,000. And then the social media listening is basically, that's just labor of these M&E officers. And roughly speaking, we had an assumption of that a country would have one person doing this work per 10,000 population. And then lastly was social mobilization, these sort of classic new vaccine introduction activities, which we assumed would happen more close to the service delivery points at the facility. And so that was just a flat amount of $750 per facility. Interestingly, so I thought this could be useful for this group, this IHEA group. So we had these costs we had several things where we had labor costs, where we had people like nurses or other technical workers, and we had to come up with an assumption about the wages for those folks. And there we relied on this paper. I don't know if I could pronounce it correctly, but Sarah J. and Melanie Bertrand and Jeremy Lauer, this is WHO group, that estimated health worker salaries as a multiple of GDP per capita. And so we used those in order to come up with wage levels for the inputs where we needed wages. So results. So in the first scenario that we were asked to do for COVAX, basically had the idea of focusing on these 92 advanced market commitment countries. That does include India, but there was a sort of a different assumption about the amount of doses that India would get. So that's why India is always broken out. But generally, the idea was to try and reach 20% of the total population of these countries, or that was the target. And it was assumed it was going to be a two-dose vaccine, and that it was a relatively short time frame over which the vaccines would be deployed. And I'll just note to you, in case you're not familiar with it, that COVAX also has these self-financing countries, several self-financing countries. And in this initial work, we didn't look at those. So we didn't estimate costs for them. Those tend to be wealthier countries. So in this initial scenario, the prioritization of populations was to start with core health workers, and those were going to be reached through the delivery modality of a fixed site delivery. And then the second priority group would be the elderly, and that actually, and then you have, and the elderly was broken into, or the older, I should say older individuals was broken into 65 and older and 50 to 64. And then all the other adults would be less than 50 years old. And so that was the prioritization order. And the reason to have this prioritization is that each country got a specific amount of doses allocated to it based on its total population size. But their numbers of health workers and the distribution, the age distribution of their population varied. So in some cases, coverage of certain priority groups would be higher in some countries than others because of the, they all got an allocation of vaccine that was just purely based on their total population, but not based on the size of their priority populations. So anyways, you can see here that, in fact, in most of these countries, based on the doses that we were given data about the number of doses that would be supplied to the countries, we didn't really reach all the way to 20% coverage. And you can see also the breakdown that we got, most of the doses, pretty much the healthcare workers reached 90% coverage. That was an assumption. And then the 65 plus reached 80%. That was the cap max assumed coverage. And then there weren't enough doses left to reach 80% coverage of the 50 to 64-year-olds, but it reached up to 52% coverage for that group. And then in a few countries, there was some spillover into the younger groups because the amount of doses they got was so many that they still had doses left over even after they vaccinated everybody over 50. So you can see there's a few countries where some doses went to younger groups. In terms of costs results, these are the results broken down by countries that are still Gavi eligible. India is broken out. Countries that are Gavi transitioned, and then you have non-Gavi countries. These are countries that made it into the AMC because they're IDA countries or other criteria. And so this shows the breakdown of the spending across those categories of countries and what the cost per dose, the delivery cost per dose is assumed. And let me highlight that this doesn't include the cost of the vaccine itself. This is just to deliver it. And I also wanted to, and then you have a cost per person fully vaccinated with 2 doses. So all in all, this initial estimate, I should mention, we added on this technical assistance and these global and regional costs for different innovations and research studies and so forth. There was a number of add-ons here that I didn't speak much about today, but they accounted for about 15% of the total cost. But it came to about $2 billion to deliver 1.2 billion doses. So it was about $1.66 per dose once you added the technical assistance and the global and regional costs on there. I think it was something like more around $1.40 or $1.30 without those costs. And we could then also break down the costs according to the category. So there were a bunch of upfront costs or startup costs for planning and coordination and training and social mobilization and buying cold chain equipment and preparing the pharmacovigilance system and buying some hand hygiene materials, that hand wash stations and such. And then there were recurring costs, which basically, these are costs that are, for the most part, variable per dose or variable or recur as long as the vaccination campaign is ongoing. And then the total. So you can basically see the breakdown of how each one of these line items contributes to the total cost. And now let me show you some updated results from the version 2 of the model. And if you recall, in version 2 of the model, we extended the time horizon and we allowed these costs to recur, some costs to recur every 6 months. We did do some revision of the input costs, and most of those went in a downward direction from the first version. The other major change was that at this point, we had information from countries themselves in terms of what they were planning from their national vaccine deployment plans, NVDPs. So we could see that most of the countries actually planned to deliver the COVID vaccine through fixed sites. And our initial assumption had been the opposite, that it would be mostly outreach and campaigns. And the cost per dose for outreach and campaigns is significantly higher than delivering through fixed sites because of the transport costs and the per diems. So a big reason for in version 2 for our costs to be lower is that we basically shifted dramatically towards the fixed site delivery modality. Anyway, so, and the other thing we added in was the self-financing countries here. And we also added in the cost of the vaccine itself, which that's new as well. And in this scenario, it's a 30% coverage scenario. But maybe the thing to focus on is the average delivery cost per dose delivered, which is the last column. So if you recall, in our first estimate, it was like $1.66, and here it's down to 75 cents. And that has a lot to do with two things that I mentioned, revision in input costs and shift in delivery modality. And the third thing that I didn't mention yet, but is a big factor, is that there are a lot of fixed costs in this model. And so when the coverage scenario is revised from 20% to 30%, those fixed costs are getting spread over a lot more doses delivered, which is obviously going to push your unit cost down. And so really part of this is just an artifact of spreading your fixed costs over a larger number of doses. And then finally, my last slide, I just wanted to flag a little bit of the more interesting things going on with this version 2 model and the challenge, maybe for this audience, given it's an IHEA audience, how to properly deal with human resources for vaccine delivery. If you recall, I mentioned in the very first estimates we did, we were just asked to leave them out under the idea that it's not something that COVAX was going to be fundraising for. It's not part of their ask. The assumption was that the countries would supply the labor to deliver the vaccine. But later, there was a lot of interest, I think, in understanding, well, how much labor would be required, and is it going to be necessary to, increase labor, or is it really going to be that health workers are redeployed from something else that they would be doing to doing delivery of COVID vaccine? And so here you can see our sort of first attempts to deal with that. So there were a number of assumptions that a group at WHO came up with in terms of the amount of minutes per dose delivered, labor minutes per dose delivered, and the amount of hours per day and days per week worked, and all of that information. And then the mix of teams, vaccine teams, what's the composition of those teams, and then a critically important assumption down at the bottom, staff allocation, which is basically your assumption of what amount of your existing health workforce can you redeploy to deliver COVID vaccine. And here it's capped at 5%. And so if you have human resource needs that go beyond that 5%, then that's like new budget. That's new money you need to spend by paying people overtime to work extra hours or hiring new people to do work. if your needs are under that 5%, then there's still an opportunity cost because that's a worker that's being paid to do something, and now they're doing something else, which is deliver COVID vaccine. But it's not like it's not additional cost, it's more of an opportunity cost. So that's handled here. So here's the delivery cost without HR is the 75 cents per dose I mentioned before. And then if you just add in what's called surge HR, which is this extra labor you need above and beyond what you can redeploy from your existing workforce, that increases the costs almost more than double to $1.85 per dose. And then if you count the opportunity cost of all of the labor that's expected to be needed, you end up with quite a higher price tag of $4.18 per dose. And again, that last one you can kind of think of as the opportunity cost, because it's not necessarily new budget. These are workers that were already being paid, their salaries were already being paid. It's just that you're shifting what they're doing with their time. So I will stop there. And I know there's a lot of questions in the chat, and I also welcome questions from the audience. I don't think we have a moderator, so I would just encourage you to ask your question if it's quiet, or otherwise you can raise your hand and I can call on you. In the meantime, I'll take a look at the chat. So to Arindam's question about, is there any literature on the cost around adult vaccination campaign? So there is quite a bit of literature. That's really what I was describing, the work that ThinkWell did to try and draw from that literature about, and I see the question is actually more specific to specifically adult vaccination, as that might be different than childhood vaccination. And some of that literature did involve, flu vaccine, but most of the literature is still on vaccines for children, for what it's worth. Interestingly, also, there's a question about cold chain and the additional space for cold chain. Indeed, that was included in this model. And there's a group that provided estimates of the cold chain, the additional cold chain that would be required in each country. As I understand it, they had, for some subset of countries, they had information about the existing cold chain capacity, and for many countries they did not, and they had to make some assumptions. And in terms of the ultra cold chain I should also mention that the cold chain scenarios vary depending on how you were going to organize the cold chain into hubs, like a national hub and regional hubs, or whether you're going to go down to the health facility level, and so forth. And then there was the issue of ultra cold chain. In everything I've showed you today is not including costs for ultra cold chain, but this larger working group is working on that and considering, how to include that. One of the things that we did not do in great detail is deal with the idiosyncrasies of different vaccines. So obviously there are some vaccines that you only need one dose, and there are some vaccines where they require a different cold chain infrastructure. And depending on the mix of vaccines that a country is planning to use, that could have implications for the costs. And that level of sophistication we really haven't undertaken here. But I will give a little bit of a plug for the WHO's CIVIC tool, which is a country planning tool that individual countries could use to do a more granular costing for their country and that tool has the flexibility to account for different vaccine products, some of which may only require 1 dose, some that require 2 doses, and what that means. And then also can account for cold chain more specific to the needs of that country and the particular vaccines it's using. If anybody, I'm going to keep going through the chat, but if anyone wants to make a comment or a question live, I welcome that. The next question is, pharmacovigilance may account for active adverse event surveillance apart from routine passive reporting. Yeah, that's true. I mean, there are some pharmacovigilance costs in here. And I do also want to reiterate that there was a large team of people contributing to this and to the assumptions for different components of the costs. So, you know, there was a group that, helped us understand, whether pharmacovigilance would be included at all, and to what extent. Another issue that came up was, electronic registries or, electronic type vaccination cards, and whether we should have a line item for those, and whether for some costs, like the pharmacovigilance, I know there was discussion about whether this would just be subsumed into their regular pharmacovigilance or whether there were additional costs specific to COVID. I see Logan made a response to an earlier question. Staggered session planning, yes. So again, with just to Arindam's point about staggered session planning to prevent overcrowding, in some work we did earlier that ThinkWell and also Allison Portnoy, my colleague, was involved in, we tried to estimate, the additional costs of even routine vaccination in the era of COVID. That was a work we did prior to there being a COVID vaccine, but in that case, we considered, extra costs related to crowd management, to keep people socially distanced, or to have the dividers so that people queue at a certain distance from one another and so forth. And so there could be some extra costs for that, including for people who are sort of monitoring the crowd as it's queuing and making sure that that's going smoothly. Those types of things, again, that level of detail can be more estimated, or modeled with more detail in the civic tool. And later in this seminar series, we're going to see some presentations related to the civic tool, so you can see that. But that nuance in terms of, session size and so forth, you can deal with there. Yes, so Sarah Tuffer makes a good point that, in the shift to fixed site delivery, there could certainly be costs that we haven't accounted for that fall to the patient, really, in terms of getting to the facilities where the vaccine is, and whether, you'd have to account for those costs or spend more money to mobilize them to come to the facility versus in an outreach context. I think that's a good point. I'm not sure how explicitly we really have dealt with that, because our social mobilization costs, for example, are agnostic to the delivery modality, which may be which may not exactly be the best assumption, as you point out. Damian Walker, are there efforts on the ground to collect actual data? Yeah, thanks, Damian. Yeah, so that's actually also part of this next phase, is that now we have a lot of, when we did this the first time around, there was no countries there was no vaccine available yet, actually, when we started this. So no country had done any vaccination. And so everything was an ex-ante projection. Subsequently, the first piece of information we had from the country level to kind of validate our assumptions or check our assumptions were these vaccination plans, these NVDPs that countries did as they're sort of applying to participate in COVAX. And those had budgets in them. And so and they had details of their plans. So that was where we could start to use some information from those. The biggest example I gave you was that it changed our thinking about the amount of vaccine that was going to be delivered through fixed site. And then now the next piece of information we have is that a number of countries have gone through this country level planning with the civic tool. And so they're presumably, working at a much more granular and informed level about their local context to estimate the costs of delivery. And, one of the things we're seeing is those costs. I've been involved in a few of them and have seen some reviews of the costs estimated across these countries, and they vary widely in terms of the unit cost per dose delivered, and in terms of the assumptions they make about whether per diems are going to be paid to who and so forth. And so there is a big variation from country to country, but I think ultimately there's elements of those plans that we can also use to refine our assumptions. And then finally, at some point, I believe there are plans for doing actual costing studies of COVID vaccine delivery in these countries. So empirical, gathering of to try and estimate what it actually costs and what did they actually achieve. And of course, that would really help us. Probably by the time that becomes available to us, it might be too late in terms of the kind of high level costing that we're doing here to inform resource mobilization. But it'll still be interesting, at least as an academic exercise. It'll be interesting to see, how accurate or inaccurate we were in making these cost projections. Yeah, so there's a question from Lin Hutan about the sort of concern about the delivery modalities and whether outreach is more effective to reaching the most remote and difficult to reach parts of the population. And so, I think there's been a lot of there's a lot of uncertainty among our group about how COVID vaccine is going to be deployed. We're assuming that there's going to be a mix of strategies and that there are certain parts of the population that are going to need to be reached via a remote, via outreach, because they're remote from any facility or they're just not motivated to come into a facility. So, there does need to be some aspect of outreach, one would expect. But I think we'll only learn about that the more that we see in terms of what countries are planning, and then of course what they're actually doing, and how well it's working. I know I see we're sort of coming up against our time limit. Let's see, I've got another question. Yeah, so the next phase of the exercise, so really the next phase now is we're working on scenarios for COVAX and WHO that are much more scaled up than those initial. Our initial scenario really was only trying to get to 20% coverage, but now they're looking at scenarios that go to much higher levels of coverage, some of which also contemplate booster shots. And so we've got that coming in our model now to deal with booster shots. And what else? I guess that's the main one. The other issue would be, if eligibility, if we get eligibility for younger age groups, then that also changes the sort of scale of the population that's eligible. And then, there's the question of prioritizing populations for vaccination, according to risk and so forth. And I know there are other groups, there are other groups working on sort of what makes sense in terms of cost benefit, in terms of prioritizing certain populations over others if you don't have all the vaccination supply you need to do everybody, or it's going to take a long period of time to vaccinate everybody. Who should you vaccinate first to get the most bang for the buck? And questions of that nature. I think we started out with the initial scenario really had a short time horizon of deploying enough vaccine to cover 20% of the population within like a 1-year time horizon. But more and more, it seems to me that we're going to have to accommodate a rollout that happens a little bit more gradually, or is more varied across from country to country. Finally, I just wanted to mention that we do have now several countries in our original set. We have several countries that have already reached very high levels of vaccination. And so there's a lot to learn from those places in terms of what kind of fixed cost investments, what did they spend on social mobilization, to reach those high levels of coverage pretty quickly, and what did they need in terms of, HR, surge capacity, or redeploying workers. Those are the big questions, I think, that drive a lot of the delivery costs. So it would be interesting to see, obviously, the countries that are early adopters and had a lot of success early on may not be representative of, the realities in other countries. So, there are limits to what we can learn from those settings, but nevertheless, that'll be useful to look at. I think I should probably stop there. I'm happy to entertain more questions, but I think we're out of time. I believe this session is being recorded for future viewing. If you know anybody who couldn't make it or might be interested, I'm happy also to take follow-up questions by email. If anyone wants to reach out to me for more information, I'd be glad to be in touch. And I'd encourage you to also keep your eye out for the next sessions in our webinar series, because I think they're all going to be quite interesting. All right, thanks a lot.